Good afternoon, ladies and gentlemen, and welcome back to RSM Live and to our first webinar of 2001. I think it's a bit late now to wish you all a happy new year, and it's not particularly happy anyway, but we last met 3 weeks ago when I was talking to Cliff Stock about policing the pandemic. And I'm pleased to say that not much has gone on in the world over the last 3 weeks. Well, there was Brexit, there was a mob taking over the capital, the virus is out of control, the NHS is on the brink, but other than that, nothing much has changed. But indeed, what also has changed, of course, is that for the first time, we've now started our mass vaccination program against COVID. Over 1.3 million people in this country have already been vaccinated. So only, how many is that? 49 million still to go. But nevertheless, we've made a start. But it makes the topic for today about as topical as it possibly can be, because we're going to talk about vaccine hesitancy and all those issues around why not everybody seems to be as keen as others on taking the COVID vaccine. Now, I just want to make clear that that is the subject today. We're not talking about the how vaccines work. We're not talking about our particular vaccine program. All of that will be coming up in the coming weeks, as is obviously certain to do so. This is very much about the social, psychological, political, ethical issues that exist around the problem of vaccine refusal or hesitancy. Now, we couldn't have two better speakers for this. First of all, Professor Heidi Larson. Heidi is a very distinguished anthropologist, a graduate of the Harvard School of Public Health, chair at the London School of Hygiene, and is director of the Vaccine Confidence Project. So cometh the hour, cometh the woman, and indeed cometh the book. A book on called Stuck is now out. Heidi, you actually wrote this just before COVID, and I think you showed great courage actually not to alter it or kind of update it for what had happened in the weeks between presumably your proof and then the book coming out. But it's actually, I think, all the better for that. But there we are. We have a great person with us, and indeed do buy the book. And second, Professor Michael Parker. He is a sociologist, director at the Wellcome Centre for Ethics and Humanities and the Ethics Centre at Oxford University. Principally known, I think, for your work on genomics, but also global health research, data science, and so on, all of which are incredibly relevant to the current crisis. And you are, I think, the 8th member of SAGE who has joined RSM Live. So once again, you will be leaving. Because we've cleverly timed all our RSM Lives to be with the SAGE meetings, just to make sure we're absolutely up to date. And can we once again ask you, please, when you do leave, would you leave your video and microphone running? I'm sure that will add to the gaiety of nations. Right then, let's get started. So Heidi, your book opens with you returning, and I quote, as an anthropologist living and working in some of the poorest countries of the world. When I came back, I did not expect to come back to the United States and Europe to witness an emerging tsunami of skepticism about one of the most tried and trusted and true life-saving interventions in modern history, namely vaccination. And that was written before COVID. So kick off then about how you came back into this world, as it were, and what were the starting point of some of your thinking and research.
Thanks, Simon. Indeed, I had been working with the UN, particularly with UNICEF and WHO, and had worked on the launch of Gavi, actually, and the introduction of new vaccines. And coming from having worked a lot in AIDS in the decade previously, I was thinking that the vaccine space might be a bit dull compared to what we were dealing with HIV and AIDS. But in fact, I coincidentally joined at quite a turning point with vaccines, and from 2000 to 2005, working on introduction of new vaccines around the world, as well as polio eradication, which was a very old vaccine, but in a different eradication effort, which is hyped up quite extensively. I just left, right, and center, ended up doing a lot more crisis management than proactive communication. But I thought, when that happens in remote areas of India and Nigeria and other places in the world I was, somehow you can explain it away for awareness or access, but then landed back in the US at UNICEF headquarters on vaccine issues. And indeed, it was a lot of questions coming up, and more. And the big question that I had, well, when I tried to raise awareness about this, the big question that came to me was, well, how big of an issue is it? Has it gotten worse? And I couldn't say it had gotten worse because we had no benchmark. So the whole objective of leaving UNICEF and founding the Vaccine Confidence Project was to really map what was going on in the world, get some metrics around the messy emotions and perceptions in space of vaccine hesitancy, and get some benchmarks and keep our finger on the pulse through increasingly social media, but surveys and others. And indeed, we just published, as I shared with you earlier, an analysis over time. One thing about having a metric is you can look at trends over time. And we're in a pretty volatile space when it comes to vaccines. And COVID has certainly brought that out big time.
Now, of course, it's nothing new. And indeed, at the start of your book, you give us a brief outline of the history of vaccine, whatever we're going to call it. And we'll come on to definitions in a second, actually, because I think that's important. But it goes right back to Jenner and smallpox, doesn't it? Almost immediately after Jenner. Do you want to just tell us just a little bit about, it's always good to have a little bit of plus ça change.
Well, Jenner and the smallpox vaccination, actually, the very first formally organized anti-vaccination league was here in the UK. And actually, it was called, it wasn't the vaccine itself that provoked it. It was the day that the government put a mandate on it. And it was actually the anti-vax. I've gone through the archives in LSHTM, the old pamphlets, and it was the Anti-Compulsory Vaccination League. And to be honest, some of the themes, I could pick passages out of these 1850s, 60s pamphlets that are now on social media in a different context. And so I think the three big themes that have stuck with us, although the modus operandi has changed, are liberty, the libertarian, don't tell us what to do; purity, this is against God's plan, it's not natural; and safety. This doesn't feel right.
And indeed, I think the very first one was in Leicester, the Leicester Anti-Vaccination League of 1852, yes. I think, or three. Yeah. So well done, Leicester. Always doing well in football and doing well in anti-vaccine. Okay, so it's not new, and as you say, some of the themes have been with us now for over 150, 170 years. Can we also just start with just a little bit on definitions here, because there's all sorts of words used as vaccine denial, vaccine hesitancy, vaccine skepticism, conspiracy theories, etc. Do you want to, again, as obviously this is so much your topic, you prefer vaccine skepticism, I think, but could you just explain a little bit about the terminology here?
I've framed our research as confidence, a bit inspired by the Consumer Confidence Index, because we wanted to develop an index, and confidence linked itself more to measuring than the trust in a way. But you can have 0% confidence and you can have 100% confidence. And we wanted to, if nothing else, bring out the fact that this is a very diverse range of sentiments. What has been concerning to me, and this is part of the broader geopolitical environment and nationalism, it's become hugely polarized. And WHO, and actually it was SAGE, the WHO Strategic Advisory Group of Experts on Immunization, that came up with this term hesitancy. And at first I thought that was pretty negative, and I stuck with confidence in our framing. But I did grow to appreciate that it brought in a new term that recognized that everything was not either pro or con. and it did open the discussion more. And I was on the SAGE advisory group on vaccine hesitancy, where we framed it. We did a landscaping, came up with some metrics. So I use skepticism actually I try to avoid the word anti-vax. The problem is it just buckets everything that's not pro into that. And I think, as you saw in the book, I think we're really alienating a lot of very genuine parents with genuine questions, or even individuals, because they feel like if they start to ask any questions, they are labeled as anti-vax. So I think words like hesitancy and skepticism, it gives it a more gives it a more open but questioning framing.
Okay. Now then, let's then get on to some questions then. So both Jenny Shaw and Mary King are asking for some figures. What's the current proportion of vaccine skepticism, hesitancy, etc., regarding COVID in the UK? Now, we don't normally, I think we anticipated this question quite easily. It was fairly obvious it's going to come up. We don't normally allow people to show any slides, but we're going to make one exception for you, because I think this is something that you need to show. So this is from you. Just take us through this. You very nicely put the UK there. What this is showing us, and also when this is, where this data is from.
For the last 5-8 years, we've been running our vaccine confidence index with our polling partner. It's one of the network of Gallup International groups, Orb International, and this was from and we've been running a lot of surveys with them globally on just vaccine confidence more broadly, but within that we've situated questions about COVID vaccine willingness. And this is from a December, just run last December, last month. We've been doing it, particularly in the UK, more frequently, collaboratively with Orb, and globally in different waves. The UK is not bad. They're sort of in the middle. I mean, this is not the whole world, but it's, trying to catch quite a spectrum of countries. I think, it is not surprising that there's quite a few, France, Germany, Slovenia, Poland, Croatia. What's interesting to us is to see that where countries are on the COVID vaccine willingness spectrum is not that dissimilar from the broader vaccine confidence metrics we have gotten in the last 5 years. So what it does say is that background vaccine confidence is one of the predictors of COVID vaccine willingness. Not everywhere, because some places have a specific issue about the COVID vaccine. But the UK is in the middle there. But what's interesting is that in a number of these countries, they've gotten less willing in the last 3 to 4 months than they were.
Michael, would you like to speculate, on why that might be? One would have predicted that they would have gone the other way, or is that because people falsely thought it was all over by the end of by the summer?
Heidi's probably the best place to answer that question, but I think it's probably worth saying something. So for the 2 years leading up to this year, I chaired a Nuffield Council on Bioethics working group that Heidi was on, which was looking at the ethics of researching global health emergencies. And one of the things that emerged from that was importance of questions around community engagement and trust and public confidence in co-production in terms of the success of medical research in global health emergencies. So one of the things I guess I would want to say is that we need to think about confidence and trust in relation to vaccines, but we also need to understand that in the context of a broader set of concerns that people in communities might have about research, about medicine, and those kind of things. So it doesn't surprise me that the perceptions of risk around, questions about hesitancy and confidence change depending on the whole range of other factors that are in the social world around that at any one time. So, but Heidi is probably best placed to answer the specific question about why it might have changed now.
I mean, the fact that there's a relationship between trust in institutions, trust in government, and trust in vaccines, etc. I mean, that is a little bit of the kind of no shit Sherlock moment, though, isn't it? I mean, it would be bizarre if that wasn't the case. Can we look in, Heidi, can you take us a bit more deeper than that? You know, what other issues are there as well that seem to be, well, both that connect all these, but also interesting discrepancies?
Well, I think, I mean, Mike brought up the word risk, which is very much, this is very much about risk and risk perception. We've been, as I said, since in March, April already monitoring sentiments about COVID vaccine. And actually, the willingness was high, not high, but relatively high, and certainly higher than the rest of the year back in April, May. But there wasn't a whole lot of discussion about vaccines then. I mean, then it was mask, no mask, you know, 1 meter, 2 meters. We were much more scrambling to figure out, you know, what we had to do to manage this or control this pandemic in the absence of a vaccine. And vaccines were not really that much of a discussion. So it's much easier to say, oh yeah, I'd take one when it's far away. As the summer went on and the imminent threat of the pandemic felt like it was waning, even though, you know, all signals said it's gonna come back. The willingness to take a vaccine by September had dropped quite a bit. It inched up a little bit in October when you started to see the resurgence pretty badly of the vaccine, but I mean, not of the vaccine, of the virus, and you know, it was looking pretty bad again. But also what's happened, and I think part of the contribution to the dropping willingness was that there was a lot more out there in the media, in the discussions about the vaccine candidates that there weren't in April, May. And with all that new information about the multiple vaccines, all the trials, all the differences, came a whole tsunami of misinformation. So for every new piece of information about vaccines, there was, I would say, almost tenfold of all kinds of interpretations of it, misinterpretations and purposeful diversion. So it was part of the information landscape alongside people having, there was a fantastic article in New England Journal around 2009 by a physician, Danielle Offery, and she wrote a piece that she called Emotional Epidemiology. And actually I've been in touch with her this past week because I love that term. It really reflects that, you know, she said in the beginning of 2009 pandemic, people were saying, where's the vaccine? Where's the vaccine? But by the time it came, they didn't want it anymore. You know, the risk of the vaccine versus the imminent threat wasn't there.
So again, it's, I think, fairly clear that the greater the threat people perceive to themselves or even more to others, the greater the willingness to take a vaccine. But two people already have asked the question. I think it's UK relevant, but not just UK at all, but nevertheless partly is, which is about what do you think that he was going to come up sooner or later, but he's come up sooner. Shirley Franklin and Colin Bownett both asked the lingering impact of Andrew Wakefield and MMR, which is one of the things that had changed by the time you returned to US and UK. Do you think that that relates to the current issues, or it's a separate, it can be kind of compartmentalized separately? I think we can argue it both ways, but you talk quite a bit about Wakefield in your book, Heidi.
Well, I think that the specifics of, you know, the MMR vaccine and the anxiety in general about vaccines and autism, I think it's less about the specifics of that perception and more about what it does have in common is Andrew Wakefield, as I mentioned in the book, got lucky. I mean, his paper came out, you know, as Google was opening their doors, and it was before even Facebook and Twitter, which was not even until 2006, 2007. So
Yeah.
1998. And so what Wakefield has done between the being there on the eve of the digital revolution, as it were, and himself personally taking this on as a mission and becoming a martyr for the cause, as it were, he was one of the earlier ones to, I mean, since Lester, purposefully organizing a movement. And I think it is more about the nature and the dynamic and the example of a movement that has really been, let me say, inspirational or motivational or incentivized others to jump on with their issues and all kinds of other issues. If you follow the Wakefield story now, you'll end up in all kinds of different spaces that have nothing to do with MMR, but they've jumped on
Yes.
the wagon.
Probably, I mean, it's probably worth disaggregating some of the things, because I think that, you know, there's going to be a whole range of reasons why people might not have confidence or maybe hesitant, and some of them are going, you know, and so I think it's probably worth breaking those down, because there will be people who've, you know, got perfectly reasonable worries about risks. You know, they don't have enough information. They think, well, look, this was done very quickly. You know, can I be certain? That sort of thing. There'll be some other people who've got, you know, completely unfounded but unshiftable beliefs, which just mean that that's that they're never going to change their mind. There'll be some people who've got various kinds of misunderstanding. There'll be people who are free riders who just think, you know, well, if everyone else does it, I don't need to. And there'll be other people who have strongly held legitimate beliefs, religious and cultural beliefs around the nature of the vaccine, for example. You know, and so I think those groups will need to be understood in different ways, and some of them will be associated with Wakefield and so on, but the majority probably won't be. There'll be other reasons that they've got. But I think we need to, if we're going to make progress, we need to disaggregate there. But we also need to disaggregate around risk, I think. And one of the things that's clear, I think, from the experience of the last nearly a year now, is that there is no risk-free option. There are people who think, you know, these vaccines are risky, but, you know, lockdowns are risky. You know, travel movements are risky. Taking kids out of school is risky, and not having a lockdown and just letting the virus run free is also risky. So, you know, the risks associated with vaccines need to be understood in the context of the hesitancy needs to be understood, but both on the one hand in a disaggregated way about different sets of motivations and worries, and on the other, when it comes to risk, you know, I think we just need to be better at just recognizing, and this applies to members of the public as well as kind of experts, that there's no risk-free option here. And that comes down, I think, ultimately again to questions about public engagement, co-production. There's a whole range of ways in which people can be brought on board in ways that create confidence.
Can I ask you a specific question, Michael? I should immediately declare it. I used to know Andy as he was then, before he became Andrew Wakefield, and go skiing with him and things like that. But obviously not since he became Andrew Wakefield. But there is a difference, isn't there, between MMR, which was about the risk that a parent was taking on behalf of the child. And of course, in COVID, we're talking about adults. Okay, a child has no moral agency, doesn't take the decision. But it was quite clear from what was going on during MMR, people were happier to take the kind of chance of providence or whatever that a child would get measles than they were to give an actual intervention that would give a child autism. And that's not really part of the COVID dialogue or risk analysis that people are making for themselves.
I mean, there are going to be a whole range of reasons, coming back to the point, there are going to be a whole range of reasons why people do or don't do things. And the world around COVID is, as you just said, is radically different to the world around MMR. Yeah. I mean, I think that, I mean, firstly, you know, there's been a bit sort of slightly I don't know what the word is exactly, but the way in which the effectiveness of these vaccines has been discussed in the media hasn't, I don't think, been completely helpful. So we talk about a vaccine being 70% effective or 90% or whatever it is, depending on which one. But actually, you know, that's only part of the story. That's the effectiveness in a particular body. But of course, you know, once you think about this as a population level intervention, if lots of people use it, then the effectiveness, you know, goes up. So this is about this is about us doing something together as well as doing something to protect our own bodies. And that raises any important questions about people's obligations. And as you say, that in the context of children, there's one set of questions about MMR and what should I do this for my child. But here in the world we're in now, this is about it's very hard in the current in modern society, but we do have to think of ourselves as doing something together for ourselves and for others.
Fair enough. Okay, now we're getting lots of questions that are actually fairly technical about vaccines, and I think the person we're having on next week will be better off on that, and also on the new variant, and definitely we'll be able to tackle that one directly next week. But a lot of other people, too many to actually list, are asking about what is the best way of addressing these problems, both on a population level and an individual level, and how do we respond? So let's move on to that a bit, and one that's come, I can see quite a few people asking now, is about, they're obviously talking from various different perspectives, but one person asked about care workers, another about peer colleagues, etc., who express vaccine skepticism or go as far as denial, about the different approaches and how should we respond to this. So Heidi, you devote a lot of your book to this, and let's start out with one of the obvious ones, which is, although it's very tempting sometimes and often goes down well on Twitter, but probably the first thing to say is this is not an argument you can win, as it were, in the normal sense of winning an argument. You said to The Independent recently that all that happens is someone with a deep view, their views get even deeper. So do you want to outline a bit about what doesn't work when dealing with a co-worker who expresses fairly strong or medium views in this area? Let's talk about what doesn't work.
Well, I think assuming that information is the problem definitely doesn't work. It can aggravate some people because then they feel like you're really not listening to them because they have another issue, whatever the issue may be. And I always try to start by listening. And when they say something that my mind is saying that it's really wrong, I mean, incorrect in a sense, I ask them why they think that way. Because sometimes, it's quite emotional. Sometimes, it's a family member or a friend who's actually had a child or a family member who's gone through an adverse event, or it's something they've read somewhere, which may or may not be true, but it's certainly they were sensitive to it. And sometimes it's more that it's not that they're as much against vaccines as pro something else. There's this whole, value-based group of moms who are very much home birth, gluten, vegan free, no contraceptive pills, just by rhythm method. And oh, by the way, that includes vaccine-free childhood for my baby or my child. And that wasn't their intention when they started with these groups, but they ended up there. So I think some of this is like telling somebody you can't believe in that religion, because it is, some of it's very much that based. And sometimes it's genuine misinformation, and that's easier. But then I think what doesn't work is to cut them off and say they're wrong before actually giving them a chance to explain how they got there.
Okay. And Michael, anything you want to bring in on this issue?
Yeah, so I mean, the first thing, the most important thing is to get sufficient uptake to make a difference. So that's an empirical, so one way of doing this is to say, this should be compulsion or something, but there might be, so, we need to think in a pragmatic, evidence-based way about how to make this happen. So, I mean, I obviously agree with what Heidi said, but I suppose, coming at this from an ethics perspective, I don't think it's right to tell people that they're wrong, and I think it's certainly to correct their facts. But I do personally think that where we can help, where we can save lives at little cost to ourselves, then there's a moral obligation to do that. So the classic example in ethics is the difference between you're on a seashore and there's a very rough sea and someone's drowning, versus standing next to a boating lake and there's a child in, you know, knee deep water and child drowning. So in the case where it can easily be done and very little risk to yourself, you have an obligation to save lives. So I think there's a strong obligation to take the vaccine myself. And I think I wouldn't, you know, I wouldn't want to kind of force that on someone, but I wouldn't be hesitant, as it were, in saying, you know, I think we're in this together and we need to, the only way we're going to get out of this current situation is by people taking this risk as opposed to the other risks that are out there.
But some people have fairly advanced kind of conspiracy theories are very popular at the moment around pharma and many other things. I saw a clip of an Italian physician, Robert Borioni, who seemed quite effective as a communicator, pointing out that, you know, pharma makes more money by treating disease than it does from vaccines to prevent it. They would love you not to accept a vaccine. That's how they actually make more money. Do you think that approach, which is kind of challenging the reasoning behind some of the more conspiratorial approaches, does that have any purpose, or again, it will just have the opposite effect?
I think this might sound like a strange approach, but I think, you know, think about the ways in which political parties try to win elections. You know, what they do is they focus on the people who where there is some potential for people to change their mind. You know, there are some people in this space who are not going to change their mind. I'm not suggesting we abandon those, but I think we should focus on where it's possible to have an impact and make a difference. And that's what our strategy should be, really.
Yeah.
Okay. Well, what about then, someone else has asked about, what about dealing with misinformation? So Heidi, in your book, I think it's not in the book, but you somewhere else, you talked about actually, you know, providing what's sometimes called pre-bunking as opposed to debunking, ensuring that, you know, better information is available, did have an effect in China, reduced the amount of Chinese herbal remedies being used or antimalarials across the world. So timely provision of information, including, according to you, from government sources, does itself also play a role? And at the end, I'm going to ask you for some good, to put on our website, some good resources as well. But do you still hang with that one, Heidi, that actually timely provision of information does help?
Yeah, absolutely. I mean, but I think we have to be out there more with good information. And I think where we have a real void right now, and we're giving the questioning and anti groups a red carpet, is by not being more engaged in the social media space. It's scary, it's emotional, it's potentially toxic, is kind of the sensitivity of scientists and healthcare professionals, but that's where the world is living right now. And I think that publics are hugely active on social media. We follow it across multiple platforms, 100 languages around the world. And I don't know when some of these people have all the time they have to be on it personally, but that's another story. But at any rate, I think we need to, what worries me is that that the healthcare professionals themselves, a number, have become a bit hesitant themselves. Partly, I think they're confronted with a lot of stuff that they hadn't maybe contended with before, but they don't want to lose their patients. Not their patients, not that's a kind of an ambiguous term in this context, but you know, they come to them for a lot of different things. And are they going to break the trust with them by alienating them around a vaccine or not? And so I find that there's a number of healthcare professionals in a lot of the interviews we've done that are taking almost a step back, to not be confrontational, to say, I'll give them all the information, but they've got to make their decision. Because I don't want to be seen to be pushing them because of the concern about the kickback. But I totally agree with Mike that, you know, if we think of the base from a political perspective, the base, the swing vote, and the opposition, we should really be there with the swing vote, because and the way we can be there is creating more resilience, have a information-rich environment that people have another story, because when they go online to look, they're not getting enough of the good stuff, because a lot of the good stuff isn't in that space.
So, Michael, then, what Serena Leaders just asked, well, surely then there should be tighter regulation of social media. But there's something around called the Streisand effect, isn't there? That by doing that, you actually draw attention to the things that you don't want to draw attention by censoring them.
Yeah, I think the management of information. Firstly, it's really important to maintain public trust, to be transparent, to be honest, and that's if you go too far down the management of information, then you undermine your own case. I think so. You've got to be very careful about that. But I do think that's not to say that attention shouldn't be paid to this. I mean, I think there are other areas as well. So some of it's social media, but for example, I went to visit my doctor a couple of weeks ago, and the nurse that was meant to be treating me was trying to convince me about the fact that vaccination was a bad idea. So, I think it's completely up to her to decide not to be vaccinated, but I think it ought to be a disciplinary offence for someone to be trying to convince patients that. So there's a whole range of ways in which
that point,
information could be managed. But yes, as you say, the Streisand effect is a good example. It's got to be done in a way that's effective and honest.
It was something to do with her property, wasn't it? And Google, as I recall. Anyway, but then there's another one then. So both Martin Bellman and Astrid Palmer, they both picked up, which I picked up as well, is that Spain is going to keep a register of vaccine refusers, which is basically the use of shame, isn't it? This is the use of publicly shaming people. Is this seems to me to be quite dodgy, but what do you think from the ethical point of view on that? I mean, it's been reported several times that Spain intends to share it with other EU nations. It seems to me that's verging on the illegal. But anyway, where are we with the use of shame?
We're against the use of shame, but but that's so. Firstly, it's quite interesting. We need to think of the way this is discussed in the UK is not necessarily the way it's discussed everywhere else. So, for example, there are countries. I mean, a good example. I work with a university in the US, for example, closely, and in that university, it's a compulsory for staff and students to have the flu vaccination, for example. And so I think the UK is not necessarily the same as other places around the world. So I think there's shame is going too far, but I do think creating a kind of social contract, if that's the right word, a sense of shared solidarity around the idea that, we all, was it one for all and all for one, as it were, to some extent, this idea that we depend upon each other. That doesn't necessarily require everyone to do it, but it requires a significant number, a high proportion of people to be doing this for us all to be well. So that's not shame, but I think it's not shame, but it is a message that's moral.
Well, mention of the Three Musketeers takes us, of course, to France. And France, of course, has mandatory vaccines, and it increased them in 2017. I think they now have 10 vaccines of compulsory in France, and 13 EU nations have some elements of compulsory vaccination. We're a little on a limb in not having that, actually. Sticking with you, Michael, but and Heidi, you've got a piece in JAMA today, so either of you actually can pick this one up. But let's talk about mandation then. Where do we stand on the ethics of mandation, and then on the practicalities, as it were? Do you want to start with the ethics, Michael, and then come on to Heidi?
Yeah, I think there's a really important distinction in ethics which often gets blurred, and that's the distinction between something being morally obligated, being morally obligated to do something, and on the other, and the idea that you should be compelled to do it. Those two things are not the same. So I think there's a very strong moral obligation to take the vaccine, as I said, but that's not the same as saying that it should be compulsory. And there's a whole range of reasons for that. But one reason might be that compulsion, as you alluded to earlier, may not be the most effective way of getting more people to do to meet their moral obligation, as it were. So I think I'm a pragmatist and an empiricist around this. I think people like Heidi, for example, who've studied this in depth and have a data-driven approach. We need to learn from that evidence. But ultimately, I think I'm not against compulsion on any other grounds than the fact that it may not be effective.
And Heidi?
I mean, I have talked actually even with the Minister of Health in France about this and how it turned out. I mean, and she said actually she was surprised that at the end of the day, she was getting thank you letters from healthcare professionals who said, we appreciate this new expanded mandate because it takes a lot of pressure off of us in having to persuade parents. It's tough right now. And that's been a help. Obviously, there were groups that were demonstrating against it, also in Italy at the same time, also expanded. And that was even more politicized than in France. We see in the US, actually, there are requirements, but there are opt-out options also. And that seems to be more acceptable, that, there's a mandate, but you have an option to step back for different reasons. I mean, always medical, but it depends.
Yeah.
I mean, I know there's a lot of anxiety in the UK about mandates, and I think there's probably a bit of that comes from history.
Indeed. But do you think, I mean, but already we have kind of mandated vaccines, don't we? In Hep B for a huge number of professionals who, you would not be able to become a surgeon if you don't have Hep B or a GP, and lots of roles across the health service that already do exist. Should we say if you're a healthcare worker, the case is stronger?
Look, I mean, one of the problems, it's complicated, obviously, because one of the problems at the moment is we've got a huge amount of stress on the NHS, and what we don't, the last thing we want is loads of people leaving because they don't want to have the vaccination. So, let's be realistic about it.
Yes,
let's be realistic about it. But nonetheless, if you ask me, there is a strong case for saying that certainly healthcare workers working with vulnerable groups. I mean, there's a lot of obviously evidence about nosocomial transmission, etc. I think there's a strong case for compulsion, but it may well be outweighed by the practicalities of a health service under strain.
Okay, so now I know we have to let you go to Sage, Michael. So do feel free to go and go with our blessings. It's clear that we've had, I think, over 100 questions have poured in whilst we've been talking, and we've only been able to touch on some of them. And I'm quite certain in the weeks to come, we'll be coming back to this subject. I suspect myself that, the first thing is that I suspect now with the current scale of the crisis, I suspect if you did your survey again, Heidi, one would hope that the number would have reduced as the threat becomes ever more pressing. And the other issue is always, intentions are not always a good guide to behavior. What people say in a questionnaire is not necessarily what they're going to do. There's also lots and lots of questions about practicalities, which aren't really what we're talking about today, but one's very relevant as well about has the kind of confusion added to skepticism and hesitancy. And again, we'll have to come back to that. The good news is that several people have been asking about the variant, the new variants that we have in this country, and also the one from South Africa. There I have an absolute straightforward message for you that Sharon Peacock, who's the boss of the Genomics Consortium, is therefore the world expert on viral mutations. She will be our guest this time next week, chaired by Andrew Jack from the FT. So that is absolutely, definitely, there isn't a better person in the world to talk to about the vaccine, about mutations and viruses. So please keep those questions in mind, put them again, and we will deal with them next week. Barbara Barton is asking again, many others asking about resources to share, and both of our guests will give us links that we will put into the system that you can pick up after this seminar. And can I also remind you, this is also a very good, well, I'm not sure it's a resource for patients, but if you're really interested in this subject, do Heidi's, as you can see, it's very short, beautifully written, not really about COVID, but I think that makes it even stronger because it tells us about all the background and the issues that we have. This time, next or Wednesday evening, our guest, by coincidence actually, is Richard Horton. And Richard Horton, a person who knows a lot about this issue from his involvement with Andrew Wakefield and 1998, an infamous paper, which will undoubtedly come up, but also the author of the COVID catastrophe. I'm getting very good at plugging people's books, aren't I? But I'll be talking to him for an hour on Wednesday evening. And again, there will be questions as well, much more broad around publication, global health, what went wrong, what's gone right, and so on. So your chance to talk to or to put questions to Richard Horton, the editor of The Lancet. And finally, to remind you as well, these webinars are brought to you by the Royal Society of Medicine. And as we say every time, but it's even more true as we start the new year, these things are free to you, but they're not free to us. And your help is much needed to continue this series. We've had some charitable help, but that's now over. So again, donations to the RSM will help us keep us going. We were hoping that we would in 2021 be able to ease off and say, gosh, let's see what lessons were learned, but clearly we are far from that place. So my thanks to Heidi. That was brilliant. And well, we knew it would be. We knew it would be. Normally now we would be shaking hands, taking you for lunch somewhere very nice in central London, but we can't do that. And we also thank very much Michael and wish him luck in SAGE, which has become our kind of post-match debriefing forum, I think. Maybe that's what they talk about. And thank you all for tuning in. We will pick up some of your questions as well that we haven't been able to answer and that Sharon can't deal with at the end of the month when we do our usual monthly roundup of issues that we couldn't cover because of time and so on. So my thanks to you. Welcome to the new year. One day we will get into lessons learned type territory, but at the moment it's very much things are happening on the ground too fast for that. And as I say, stay careful out there once again. Thank you. Good afternoon.
Thanks.